Hello friends, welcome to the video on MCQs on maternal adaptations in pregnancy. It is a sort of quick recap and also clinical application questions. As we have discussed in our detailed lecture, plasma volume during pregnancy increases up to 50% and this rise is by 34 weeks of gestation. Thereafter it remains stationary. Despite fall in hemoglobin, there is no change in MCV and MCHC value, and low MCV is also a screen positive test for conducting HB electrophoresis to rule out beta thalassemia. Lower limit of platelets in pregnancy because of gestational thrombocytopenia we have discussed in our lecture detailed video is 1 lakh per cubic millimeter, and values less than 1.5 which is mentioned in the report should not raise any concern. 2 to 3 fold increase in iron requirement is seen during pregnancy, and folate requirement is increased by around 10 to 20 fold. And vitamin B12 requirement is increased by 2-fold. So among the three, folate is the one whose requirement is increased to the maximum. Then fibrinogen, which is clotting factor 1, its level rises by around 50% during pregnancy. And almost all clotting factors they increase during pregnancy except factor 11 and factor 13. This is a MCQ question. This can come as an MCQ question. Pregnancy is a hypercoagulable state and it lasts till 12 weeks post-delivery. Cardiac output increases by around 40% during pregnancy, and the maximum cardiac output is seen around 20 to 28 weeks of gestation during pregnancy, and this further rises to around 50% during first stage and around 80% in the second and third stage of labor. So in a case of heart disease, these periods 20 weeks, 28 weeks and a labor, these are all high risk duration of her pregnancy, and if she is living far, she should be hospitalized during these gestations. Peripheral vasodilatation is primarily due to endothelium dependent factors like nitric oxide upregulated by estradiol and progesterone. Increase in cardiac output during pregnancy is primarily due to increased stroke volume, although the pulse rate is also increased, but the increase in pulse rate is not that much as compared to stroke volume. And turning from lateral to supine position may reduce cardiac output by around 25% and patient may feel giddiness. Pulmonary capillary wedge pressure and CVP, they remain mostly unaltered during pregnancy. So any change in these pressures, they raise concern. Pregnancy is susceptible to pulmonary edema because of the reduced pulmonary arterial pulmonary vascular resistance and increased flow, and also there is endothelial edema also during pregnancy. Maximum cardiac output immediate post delivery. Maximum cardiac output is cardiac output is maximum immediately post delivery. Ejection systolic murmur is seen in around 90% of the women, but if you are getting a diastolic murmur, it is not because of any physiological change in pregnancy. Then what are the normal ECG changes that occur in pregnancy? So if you come across them, so you should these should not raise any concern in your minds. There are atrial and ventricular ectopics, but they should be less than 110 per minute. Any other arrhythmias, they are not physiological. Q wave and inverted T wave in lead 3. ST segment depression and T wave inversion in inferior and lateral leads, and also there is seen left axis deviation, as we have discussed in detail in our theory lecture. Now relaxin, which is a peptide hormone, and it is secreted from corpus luteum during early pregnancy and later from placenta, it maintains the water balance in pregnancy. Because of this relaxin, which is secreted from corpus luteum in early pregnancy and placenta in later pregnancy, it acts on endothelial cells for endothelin production, and these in turn causes increase in nitric oxide levels, which causes vasodilatation of renal arteries, and then because of this vasodilatation of renal arteries, there is a state of underfilling and water retention is achieved by the tubules. Then renin-angiotensin aldosterone is activated, but there is also refractoriness to angiotensin 2 due to progesterone and VEGF prostacyclin production. Renal plasma flow is increased by up to 40 to 65%. Even after increased renal plasma flow, there is arterial underfilling during pregnancy. GFR is increased by up to 50 to 85%, and renal size is also increased by around 1 to 1.5 centimeter. In around 80% of the pregnant ladies, physiological hydronephrosis more on right side is observed and plasma osmolality falls. Salt and water retention, they are achieved due to aldosterone and AVP, arginine vasopressin. Then minute in respiratory system, minute ventilation is increased by 40 to 50%, and this increase in minute ventilation is because of increase in tidal volume. Respiratory rate remains the same. Fully compensated respiratory alkalosis is seen during pregnancy. Arterial pH is around 7.44, and on blood gas analysis, if you do, the bicarbonates, they are lower than normal. Thyroxine binding globulin is increased, and it is seen that there is fasting hypoglycemia and immediate postprandial hyperglycemia. What are the causes of fasting hypoglycemia which is seen during pregnancy? It is increased storage of tissue glycogen, increased peripheral glucose use, uptake of glucose by fetus, and decrease in glucose production by liver. Now lipid levels, they are high during pregnancy. All the lipids, they are increased by around 30 to 80%, some by 50%, but they are not atherogenic, so it should not raise any concern. LDL levels are important for placental steroidogenesis. Amino acids are actively transported across placenta. 400 microgram or 0.4 milligram is the prophylactic dose of folic acid during pregnancy, and 4 milligram is the therapeutic dose. Recommended daily allowance of calcium during pregnancy is 1000 milligram per day, and during lactation it further rises to 2000 milligram per day. And recommended daily allowance of iodine is 250 microgram per day. Now coming to some questions that have potential of being asked in your exams, either in your university exams or in your neetpg entrance examination. Now question number 1, a 30-year-old primigravida had a pre-pregnancy BMI of 32 kg per square meter. What is weight gain recommended to her? Now coming to the condition, year wise if she is taken, then she is not a high risk pregnancy because of her age. She is a primigravida and her pre-pregnancy weight BMI is 32 kg per square meter, so she is obese. And in obesity, the recommended weight gain is only for reproductive changes, which is around 6 to 6.5 kg. So answer is A, that is 5 to 7 kg. If her BMI would have been given less than 19, then recommended weight gain during pregnancy would have been D, 16 to 19. But in this case, as she is obese, it is not mentioned that she is obese. You have to think that she is obese because BMI is given. So her expected weight gain during pregnancy, recommended weight gain during pregnancy is 5 to 7 kg. The second question is second gravida, abortion 1. So she is not Paris woman with 30 weeks pregnancy. 30 weeks, that means she is in her third trimester. Complaints of faintness and giddiness on lying down. Okay, so there is some sort of hypotension, maybe hypotension on lying down position. When she turns to her side, she feels better. On examination, pedal edema is present. That means there is compression of gravid uterus on inferior vena cava and common iliac veins, causing physiological edema, maybe physiological or maybe pathological. Let's see what else is given. Her first heart sound is loud and a continuous murmur is present in tricuspid area. What could be the cause? So nothing else is given apart from her CVS examination. So heart disease, there is no such finding given which suggests heart disease, because the physiological change in pregnancy, first heart sound is loud, yes, and there is a continuous murmur, memory murmur present on tricuspid area. Yes, this is also seen. So these both the findings, they are physiological, so don't be confused for heart disease. Now preeclampsia, we cannot say preeclampsia because in this case her blood pressure is not mentioned, even though pedal edema is they have mentioned, but blood pressure is not mentioned, so it may not be a positive finding. Inferior vena cava compression, yes, and hypoglycemia, because they have the symptom of faintness and giddiness, they have given this hypoglycemia, but her sugar levels are also not mentioned. And what is mentioned for IVC compression, that there is pedal edema and she feels better when she turns to her left. When she turns to her left, the compression on IVC is relieved and the blood pressure is restored. So the answer in this case is inferior vena cava compression. Next question. All of the following are increased in pregnancy except. We have discussed in detail, so let's see one by one. Clotting factor 2. Yes, it is increased during pregnancy. All the clotting factors except factor 11 and 13 are increased. So clotting factor 2, clotting factor 1, whatever clotting factor they mention, apart from factor 11 and 13, yes, they are all increased. Fibrinogen, which is also clotting factor 1. So don't confuse if they have given instead of fibrinogen clotting factor 1. It is also increased, and we have seen that it increases by around 50%. APTT, activated partial thromboplastin time. No. These blood investigations like bleeding time, activated partial thromboplastin time, or INR, they are same apart, even though it is a hypercoagulable state, but the values they remain same. So APTT is not increased. Antithrombin, it is also not increased. Factor 8, yes, it increases. Platelets, we have seen they do not increase. And factor 11, earlier I have told factor 11 and factor 13, they are not increased. So I have given you some options how to think about it. Any of the answer with this question can come in the exam. Like APTT, it is not increased or decreased. Neither it is increased nor it is decreased. And platelets, they decrease. Fibrinogen, it increases. Clotting factor, it increases. Antithrombin, it does not increase, rather it decreases. And factor 11, it does not increase. So such question you may get in your exam. All of the following are true except in a pregnant lady. Let's see one by one. Uterine blood flow is 750 ml per minute. Yes, it is. In a gravid uterus, the blood flow is 750 milliliter per minute. In a non-gravid uterus, it is around 100 ml per minute. Uterus is entirely supplied by uterine arteries. No. In pregnancy, it is almost 50% by uterine and by ovarian arteries. Pulmonary blood flow increases. Yes. Although there is pulmonary fall in pulmonary vascular resistance, but the pulmonary blood flow increases because of the increased cardiac output and increased amount of increased plasma volume. Renal arterial pressure is low. Yes, it is low. I have told you earlier also. And cutaneous blood supply is restricted to compensate for increased uteroplacental circulation. This is a very tricky answer because they have also given you the reason that why cutaneous blood supply is restricted to compensate for increased uteroplacental circulation, but this is not true because cutaneous blood supply increases, and because of this sometimes excess sweating occurs in pregnant lady. Nasal stiffness is also seen. So this is also not correct. Now next question is, all of the following statements are true in pregnant lady except prolactin levels, they are highest after delivery to support lactation. No, prolactin levels are highest during pregnancy, and after delivery they fall, even though there is lactation, and the prolactin is the hormone which is related with lactation. The hormone level is highest during pregnancy. So our first answer is wrong. FSH remains low during pregnancy. Yes, FSH and LH, both ovarian and uterine cycles that result in menstruation, they are suspended. ACTH levels are higher during pregnancy. Yes, this is seen. And response to exogenous steroid is blunted during pregnancy. Growth hormone secretion from hypothalamus are increased during pregnancy. Although the growth hormone levels are high during pregnancy, but they are secreted from placenta and not from hypothalamus. So the fourth answer is also not correct. First and fourth are not correct. I have tried to explain you that how question can come in your examination. Now next question, Primi gravida, 25 years, comes with post-coital spotting PV at around 30 week gestation. She is in third trimester and there is post-coital bleeding. So we will say she is a case of antepartum hemorrhage. On abdominal examination, her uterus is relaxed. So antepartum hemorrhage and relaxed uterus, we have ruled out abruptio placentae. Now next, on per speculum examination, cervical erosion is seen with irregular margins and no active bleeding. At present there is no active bleeding and there is a cervical erosion. The cervix, it appears reddened. Ultrasound is suggestive of 29 weeks calculated gestational age. By date she is 30 weeks and by ultrasound she is 29 weeks, so it is corresponding. And placenta is left lateral. So placenta previa is a cause of antepartum hemorrhage is also ruled out. Her pap smear cytology shows predominance of intermediate cells with elongated nuclei. What could be the cause of her bleeding? Placenta previa we have ruled out. Cervical carcinoma in situ, it is a tricky question because they have shown you that pap smear is suggestive of intermediate cytology, cell cytology with elongated nuclei, but this is a physiological change in pregnancy. It is also, they have given the cervical erosion, it is also seen during pregnancy and it is also seen in women, those are on OC pills. Local cervical bleeding, yes, this is answer is, it is because of local cervical bleeding. There is a history of contact. She has come with post-coital spotting PV. So this question is also they have highlighted the physiological changes in pregnancy that are occurring so that you know them and you are not confused. The next question, following are the changes occur in renal system during pregnancy except. We have seen that GFR is increased, yes. Renal blood flow is also increased, yes. Renal arterial pressure is increased, no. The renal arterial pressure, the systemic vascular resistance in general and also pulmonary vascular resistance, it falls. So the third answer is wrong. And size of kidney is increased, yes, as we have seen it increases by around 1 to 1.5 centimeter. And physiological hydronephrosis is also seen in pregnancy. A 32 weeks Primi gravida comes to clinic with complaint of frequency of urine at night. She is normotensive, pedial edema is present, height of uterus is corresponding to period of gestation, urine routine microscopy is 0 to 1 pus cells, urine sugar is present, blood sugar fasting is 86 mg%. What could be the cause? So see one by one, gestational diabetes as the answer. Although you may be confused with urine sugar present, but her fasting blood sugar is 86 mg%. So gestational diabetes is ruled out. Asymptomatic bacteriuria is ruled out because urine routine microscopy is 0 to 1 pus cells. Bladder compression due to presenting part. This is a tricky in third trimester, but this is usually seen only after 36 weeks of pregnancy in a Primi gravida when the presenting part engages and it causes pressure on the urinary bladder. So third is also ruled out because she is only at 32 weeks of her pregnancy. And the period of on abdominal examination, it is said that it is height of uterus is corresponding to period of gestation. Fourth option, due to improved renal vascular blood flow in lateral position while lying down. Yes, this happens, it is said that there is pedal edema. That means there is physiological edema because of the compression of her inferior vena cava due to gravid uterus. And when she lies down at night, there is she lies down on left lateral position. This amount of fluid which is present in lower extremities, it comes back to systemic circulation, and it improves the renal blood flow and increased urine production. So pregnant ladies, they complain of increased frequency of urine at night. Answer is fourth. Next question. A 34 weeks primigravida comes to you with complaint of breathlessness more at rest. Her SpO2 is 98%, which rules out any hypoxia. Pulse rate is 105 per minute, which may be normal during pregnancy because of the tachycardia observed. Respiratory rate is also 18 per minute. On auscultation, no adventitious sounds. Continuous murmur is heard at tricuspid area. Apex beat is in 4th intercostal space. Her subcostal angle is widened. Hemoglobin is 10.5 gram %, and arterial blood gases shows mild respiratory alkalosis. What could be the cause of her breathlessness? Now see one by one. Bronchial asthma. On RS auscultation, they have said no adventitious sounds, so it is ruled out. Heart disease, they have given these findings, physiological changes that are commonly seen in pregnant ladies, to confuse you. Apex beat is in 4th intercostal space and continuous murmur in tricuspid area. They both are physiological changes, so don't be confused and don't opt heart disease as your answer. Physiological, yes, mostly because her respiratory rate is normal, her SpO2 is normal, and all other findings, hemoglobin is also normal, so her subcostal angle is widened. They have given you this option, this information only to confuse you, because subcostal angle is widened during later part of pregnancy. From around 68 to 70 degrees, say, it raises to around 105 degrees. Anemia, it is also ruled out because her hemoglobin is 10.5. You may confuse it, but during pregnancy, in 3rd trimester and in 1st trimester, the lower limit is 10.5, normal lower limit, and in 2nd trimester it is even 10 gram %. So answer is physiological. Which among the following are confirmatory sign of pregnancy? Jacquemar's sign, Ausiender's sign, Chadwick's sign, Braxton-Hicks contraction. So always remember, although Jacquemar's sign, Ausiender's sign and Chadwick's sign, they are seen in early pregnancy, but they are not unique to pregnancy. They are also seen in conditions of pelvic congestion, and Braxton-Hicks contraction, it is the confirmatory sign among these 4 in pregnancy. Braxton-Hicks contraction is not seen in abdominal ectopic pregnancies. A 21-year-old married woman comes to you with 5 weeks amenorrhea and pain in lower abdomen, complaining of fainting episodes and vomiting on exam and vomiting. So 5 weeks amenorrhea, she is 21-year-old married woman, and fainting and vomiting. Her pulse rate is 95. Blood pressure is 110 by 66 millimeters mercury. Per abdomen soft, no guarding rigidity. What will be the first test that you will be doing in her? Listen this, when a woman comes to you in a reproductive age group, whether there is a history of sexual contact or not, woman coming in reproductive age group with any duration of amenorrhea, subject her first to urine pregnancy test. Rule out pregnancy first. Then we will shift to another diagnosis. And in this case, as it is early pregnancy, yes, when she is coming with pain in lower abdomen, when she is coming with fainting episodes, it is important to rule out ectopic also. But the first test that you will be doing will be rapid urine for pregnancy test. Thanks for watching the video. If you have any queries, do ask me in the comment box. I will be happy to reply. And if you like the video, please subscribe it and share it. Thanks a lot.